Hello, my name is Martha Medrano. I wanted to present my conference topic, Are Culturally Adjusted Interventions to Reduce Type 2 Diabetes in U.S. Hispanics Effective? I would also like to welcome you to the AADE Conference of 2020. The objectives of this study are to state the significance of the Diabetes Prevention Program trial, to describe 3 methods prevention programs can be tailored to the target population, provide a path U.S. Hispanics with diabetes risk can take to be connected to a diabetes prevention program. So an overview of the talk would be to start with the relevance of this topic, then the methods of the data collection. I will also discuss the relevant studies I found in the literature review and pull the data together in the results section. And we will end up with the discussion and conclusions. So to introduce the relevance of the topic, the numbers of diabetes type 2, the prevalence is growing. So why should we care? Persons with diabetes have decreased quality of life, increased risk of complications that include heart disease, and it's also an increased healthcare cost for the country. Prediabetes is the condition in which individuals have elevated fasting blood sugar or A1C levels that are not quite in the range of diabetes yet. The target population is U.S. Hispanics, just as a reminder, and we will talk a little bit about them. So the prevalence rates of diabetes is over 30 million, with most being type 2. 12% of this number are Hispanic Americans and 7% are non-Hispanic whites. 84 million U.S. adults have prediabetes. Although the numbers between Hispanic population and non-Hispanic whites is similar, Sharrock et al. Found almost a double likelihood of Hispanic Americans progressing to diabetes type 2. And this might be explained through the health disparities in this group. So lower socioeconomic status is one of the risks. Also, along with that comes food insecurity. These are not unique to the Hispanic population, however. Limited health literacy, language barriers, those are more specific to immigrant populations. Targeted marketing of sugar-sweetened beverages to minority groups. The next one, water safety concerns, is specific to immigrant populations where they may rely more heavily on sugar-sweetened beverages. Barquera et al. Did find some federal references in terms of the participation rate for SNAP, which has decreased in Hispanic populations, and decreased access to health care, which he relates to the racial tensions in the country today. The Diabetes Prevention Program trial was a landmark study that was published in 2002. It had 3 interventional arms. The intensive lifestyle group, metformin group, and the control group. Participants all had at least one diabetes risk factor. Their curriculum consisted of decreased calories from fat, 150 physical activity minutes per week. So the intensive lifestyle group had the largest decrease in diabetes incidence at 58%. Therefore, the Diabetes Prevention Program is the gold standard for diabetes prevention program design. And here's a quick look at the methods of the data collection. So at the top here, you can see the databases that were searched, the exclusion criteria, and the articles that were actually selected for further review. So the literature review finalized in 8 quantitative studies, 2 qualitative studies, and 2 reviews. The first quantitative study I wanted to look over was Soltero et al. With their aim to test efficacy of culturally grounded diabetes prevention program in Hispanic families. It was a quantitative, quasi-experimental 12-week intervention. 58 Hispanic families concluded the intervention, and a third had prediabetes. Promotoras were used, which literally translates into promoters. However, the term was used interchangeably with community health workers. So this study used promotoras to provide the information, also bilingual and bicultural dietitians. Another part of the curriculum was emotional health, and childcare was available at one of the centers. Statistically significant results in the adults were decreases in waist circumference, percent body fat, and A1C. In the children, decreases in waist circumference, percent body fat, and percent BMI. The next study I wanted to look at is by Shepins et al. With their aim to test the feasibility and efficacy of culturally tailored interventions. It was a mixed method study that lasted 16 weeks. Very small, only 37 Hispanic adults concluded the study, and they were all recruited from a rural California clinic. So the community health workers were trained by occupational therapists, and they provided weekly home or group or phone appointments. Statistically significant results were found in decreases in systolic blood pressure, subjective sodium and saturated fat intake. Also, there was a significant change in the Measure Yourself Medical Outcomes Profile, which was a patient-centered questionnaire in which they jotted down bothersome symptoms such as stress, sleep, and social roles. The next study is by O'Brien et al. That really mimicked the diabetes prevention program trial, however, in a realistic setting. They credit their study as being the first type of study that very similar to the diabetes prevention program trial with all Hispanic females. And basically the reasoning to use the Hispanic women was for the role they play in their home and the disproportionate prevalence of diabetes in Hispanic women. So they were diagnosed with prediabetes based on a mean A1C of 5.9. Their BMI was consistent with obesity, and their waist circumference was consistent with abdominal obesity. Again, promotoras provided weekly then monthly sessions, and education materials were available in Spanish. Statistically significant findings were change in body weight, waist circumference in the intensive lifestyle group compared to metformin and standard care. No significant change in A1C was found, and authors believe this is because fasting blood glucose was initially lower than the diabetes prevention program trial participants. Of importance was that authors estimated less than $300 cost per person per year. So Fisher et al. Wanted to test the efficacy of text message support in diabetes prevention program participants. So this was a randomized controlled trial that lasted 12 months, the same as a participant in a diabetes prevention program class. 163 adults with prediabetes were either English or Spanish speaking and were randomized to the intervention or control group. So both groups were invited to attend the diabetes prevention program classes. However, the intervention group received 6 text messages a week, which contained class curriculum content. Statistically significant results were found in improved A1C, systolic blood pressure, body weight, in the Spanish-speaking group. The English group had improved systolic blood pressure only, and authors did not state whether or which participants actually attended the diabetes prevention program classes. The next study is a qualitative study by Brown et al., where Hispanic employees were interviewed at a health fair by a bilingual moderator. So the interviewing process resulted in topics they were interested in, learning healthy cooking for Hispanic dishes, possibly monthly meetings at work with diabetes prevention program content. Female employees wanted inclusion of their spouse to help break the barrier of women's role in the home. And barriers to healthcare included time restraints, lack of family support, home demands, and food and gym costs. So all 8 interventional studies had statistically significant results in one or more measured outcome. The references of all the studies are here, although we didn't go through them all in this talk. The measured outcomes that improved were decrease in body weight, waist circumference, systolic blood pressure, and the qualitative studies found workplace interventions may help with barriers that were identified in the interviews. Long-term follow-up intervention participants of a Paso Adelante study found that past participants consumed less whole milk and exercised more than non-participants. So culturally adjusted interventions are well received and produce statistically significant results. Use of culturally similar community health workers is needed. Culturally and literacy adjusted education materials are also something the participants enjoyed. And digital home, group, family-based, or workplace interventions can help with the barriers identified in multiple studies. So to conclude, culturally adjusted interventions are effective. Per lower socioeconomic status, physical activity outside the home is difficult. Therefore, home digital community activities are needed. Lack of medical insurance limits participation in national diabetes prevention programs. Policy changes to provide no to low-cost interventions are needed. Brown et al. Found that $245 billion was spent by persons with diabetes in 2015 for healthcare. WIC and SNAP programs should be connected to these no or low-cost interventions for those not insured. And nutrition and public health professionals can help establish community programs. Thank you very much for attending, and please post your questions below. Here are my references.